Well, welcome again. This time we're going to talk about a tracheotomy or tracheostomy. And a tracheotomy is a procedure for establishing access to the trachea because we're going to make a neck incision. The opening is called the tracheostomy, and people talk about the stoma that makes sense with it. So why do we do this? Well, one of them is it's overcoming upper airway obstruction. If you have somebody, say, who's in an automobile accident and they actually hit their steering wheel with their upper airway, with their trachea, and they're not able to breathe, then we're going to need to open up the trachea so that they can breathe. Some type of trauma, that would probably be a good example of trauma also. Long-term care of neuromuscular disease is another one. Continuing need for artificial airway from prolonged intubation. If you're intubated for an extended period of time, we start to see tracheomalacia, which is a softening of the trachea, or tracheostenosis, which is a hardening of the trachea. We can also see a lot of breakdown happening, so we do have to be careful with that. Another reason why we do this is sometimes we have patients who have sleep apnea, but they're unable to be able to wear the equipment they need to. And in those cases, especially if these guys that really don't have any neck, and that's what we call it, we're going to go ahead and we'll trach them, and it works much, much better for them. So this is a slide showing you where they can do a trach, and you can see how the trach goes. It's vertical trach. On occasions, you may see horizontal trachs. Vertical trachs a little bit better. Horizontal trachs, sometimes they have a tendency to open up too much for us. We need to watch that. With your trach tube, when we look at that, here's my pen. You can see the trach is below the level of the larynx, okay? So when these people are breathing, if we have a fenestration, which is a hole in the back portion of the trachea outer cannula, then that enables them to talk. What they're doing is they'll take the air in through the trach tube, and as they exhale, it can go up and go through the larynx, and these folks can actually start talking a little bit. There is a cuff on these. The cuff helps maintain the airway in place, and if they're going to talk, sometimes we have to let that cuff down so that they can pass that air around. And this is basically some of the components of a trach. Here's your outer cannula. Inside is an inner cannula. This is another inner cannula. We have two types. We have disposable, non-disposable. Disposable inner cannulas we toss. We don't clean them. Non-disposable ones, we actually do clean those and we reuse them. And this is the obturator. The obturator is this solid white piece, has a very round, smooth end on it. When the trach is being inserted, we need the obturator in this trach. We don't put the inner cannula in, but the obturator in. And then when we insert it, we're not going to tear the tissue as we go in. One of the things that you want to be aware of is when a patient does have a trach, one of the things you need to look at for when you go into a patient's room is where's the obturator. In some places, you as a therapist, if the patient coughs the trach out for some reason, you have the option of putting it back in. In some places you can't, but whoever comes in to put it in is going to need the obturator to be able to ensure that they have that trach in. And this is just a little bit more. You can see there's ties that go on the trach. This is what holds it in place for you. You have a flange. On this flange tells you the size of the trach. The size of the trach tells you what size inner cannulas you're going to put in this outer cannula. Now the thing about this is, say I have a size 8 trach, and that's a pretty big one. I can actually put a size 4 inner cannula in there. And what I've done is I've cut down the dimensions by half, and I've increased the airway resistance for this patient. So we always need to know what size trach, what size inner cannulas, and do we have any in the room when we're getting ready to do trach care. This trach has a cuff, and it will tell us that it has a cuff. If it's cuffless, it'll also say cuffless, CFS, which is cuffless. You have a 15 to 22 millimeter adapter. This is the 15. The 22 would be whatever you put on here. It could be your bag for suction, for ventilating a patient. It could be whatever it happens to be at that point. Here's your pilot balloon. This will actually blow up the cuff for us. Some people, when they go in there, they'll start to squeeze the pilot balloon and they'll tell you they have enough air in there. One thing you want to do is make sure and measure it to make sure there's enough air in that cuff. Some of the newer trachs, actually they're using saline, so it's really kind of interesting to know what type of trach you're working with. One of the things that's happened with this on occasions is that people will be tube feeding patients and the tube, whatever the feeding tube falls out, they'll go ahead, pick it up, they'll put it into our pilot balloon, and then they're actually feeding the cuff. And unfortunately, the cuffs will rupture on occasions, and now the patient is aspirating. So you always want to check and make sure that everything is the way it needs to be. The inner cannula is hollow. It has a patent portion of it. This allows us to go ahead and suction the patients if we need to. It's also, this is what the patients breathe through, and we can clean it out and toss it if we need to. And again, this is your obturator. Your obturator is a solid piece, and there's that rounded end on it. So one of the important things we need to do is tracheostomy care. In some hospitals, it's a nursing responsibility. In some hospitals, it's a shared responsibility between the nurses and the respiratory therapist. In some hospitals, it's just totally respiratory therapist. One of the things I'm going to tell you, when you're working in a hospital, if a patient needs tracheostomy care, don't sit there and just leave them. You need to go in and clean the trach for them. You need to tell the nurse, I'm willing to do this, I'm going to do this, go in there, do your trach care. The most important person at this particular point is going to be your patient. So you always want to make sure that you keep those trachs clean. We try to do the trach care at least once daily or at least once on a shift. One of the things we need to do when we're doing trach care is inspect for skin breakdown and infection. An infection can happen around the trach side. It can happen if there's a lot of secretions pooling around the side or the back of the neck. So we need to take a look at those things and see if there's a problem with it. We also want to check for skin breakdown. We may see that happening. When that happens, same with the infection, we need to go tell the nurse, make sure that we document this, and then if we see the physician, we can also talk to them about it. We're going to inspect for any obstructions. At one time, there was an article that talked about a fact that they had done some trach care on a patient, and when they went and put the inner cannula back in, the patient couldn't breathe. They pulled the inner cannula back out. They checked there was no obstructions within the outer cannula. They put the inner cannula back in. The same thing happened. After doing this a couple of times, finally they looked in. When they did, they were able to see like a little covering on the end of the inner cannula. What had happened was there were some thin secretions on the inside of the outer cannula, and whenever they put the inner cannula back in, it was picking up those secretions and was acting like a piece of film over the bottom of the inner cannula. We're going to change out either the entire trach, the outer and the inner cannula. Most time we're only going to change the inner cannula. We are going to change the gauze. We also are going to change the ties. So we had at one time some really sophisticated, really nice cleaning kits, and you can see one here. This kit has at least two areas, sometimes three areas in it. You have some sterile field to be able to put your sterile equipment on it. You have some gauze. You also have a gauze that's pre-cut. You have a trach tie at this point. Here's some sterile gloves. This is a brush that we would use for cleaning. And then this is like a tweezers that you can use to help you pull the ties through. And then you have some sterile Q-tips. So this is a really kind of a nifty trach cleaning kit. Not all the hospitals use them. Sometimes you have to put your kits together yourself. So you always want to make sure you have a gloves and mask. You also want to make sure you have suction equipment, because sometimes before you do trach care, you may have to suction the patient. Sometimes you may have to suction them during the procedure, and sometimes you may have to suction them afterwards. And there's your bag of mask again that you're going to need for you. Oxygen, in case this patient needs to be oxygenated. the kit. And then spare inner cannulas. Disposable inner cannulas come in a box. The box is labeled with the size of the inner cannula. I'm going to tell you, when you go into a patient's room, one of the things you always want to check for is that there are inner cannulas in that box. Sometimes what's happened, people have used all them up. They just left the box there. Nobody says anything to you. Where does this normally happen? You're in the middle of an isolation room doing trach care. You go to grab the inner cannula out of the box and there's nothing in the box. You cannot leave the room because the patient doesn't have their trach in all the parts and pieces together. So at that particular point, you're pretty well stuck. You cannot go in the hallway with gloves on. You cannot go out in the hallway with a gown on. Whatever's in the isolation room has to stay in the isolation room. Your best bet is to try to hit the call bell, maybe have somebody go get you a box of cannulas or spare cannulas, or see if there's any on the floors. Always check it out before you ever start the procedure. Some hospitals have stopped using peroxide. At one time, what we were doing, we would use peroxide sterile water, 50-50 mix. This is what we used for cleaning, and then we would have a little opening for a container of just sterile water, and that's what we used to rinse the trach and whatever we used to clean. Cotton tip applicators, these are sterile applicators. You have your pre-cut gauze, and sometimes you also have the 4x4 pads. Do not cut a gauze and put it under your trach. You're going to end up with some little threads, and if these threads get into the area, it's going to irritate them, so you don't want to do that. New ties or Velcro straps, the easiest ones to put on are the Velcro straps. You need to also make sure there's a new tracheostomy tube complete kit in there. Now, some people will tell you we're not going to waste the money and put a complete kit in a patient's room. Sometimes they may take these kits and throw them in a drawer somewhere, and nobody tells you that. But you need to make sure there is one in there. If something happens and that patient actually coughs that tube out and it goes flying across the room, you can't pick it up, wipe it on your scrub or your gowns, run it under a little bit of running water and put it back in. It's a sterile device. So you have to make sure that there's a complete kit in there. Do people cough these out? Matter of fact, they do. We had a patient who came in our hospital one time, and he was having a terrible time with his trach, and he was coughing and coughing, and every time he coughed, he was moving the trach out just a little bit. They were trying to get the physician to come and take a look at it. The physician was tied up somewhere else. Finally, what happened is the patient finally really took a very big cough, and he actually coughed his trach out. A syringe to check your cuff pressures. So we want to look at these patients, and we want to see, do they need to be suctioned prior to the start of doing our trach care? Your patient may cough, and suction may be required. Sometimes we've gone in there, assessed the patient. We knew they had some secretions, but the secretions weren't to the point where they needed to be suctioned at that particular point. Throughout the procedure, they were starting to build up more secretions, and they finally coughed and the secretions started coming out. And then we needed to go back in and remove those secretions. Oxygen for desaturation, because sometimes if these patients are on oxygen, we need to get these trachs cleaned, and we need to make sure there's oxygen available so that they have their oxygenation. We want to open our kit. We want to prepare a solution. If we have one of those trays that has 3 areas, what we do is we prepare 2 that had the 50-50 peroxide sterile water, and then the last one we actually put just sterile water in. Hospitals that are not using peroxide anymore, you can have 2 of these, at least 2 of these with sterile water, 1 for cleaning, and then you need the second one for rinsing. This is a sterile to clean procedure. When you start it, it's sterile. By the time you finish, it's clean. And this is really important because people forget to do this. When you're working with this trach, you must always hold on to the flange. And people will go, well, I don't have to, the trach ties are still in place. Okay? If that patient is coughing and he's moving the trach a little bit, he can actually move it out, and now you got a problem because the trach is misplaced. The other part of it is, once you do take those ties off, you need to make sure you hang on to that trach because the patient can cough and cough that trach out. It happens, and people don't believe it until it happens to them. The other thing is when you're either removing the inner cannula or putting the new inner cannula in, you need to stabilize that flange, because if you're pulling it out and not stabilizing the flange, now you're pulling on that outer cannula. It's going to move up in the airway. When you're putting one back in, if you're not holding that flange, you're pushing that trach now into the airway, and this patient's going to cough, and this patient's going to have some issues with you. You need to tell the patient what you're doing. Sir, ma'am, we're going to go ahead and do your trach care, get it all cleaned up for you. If we need to, we're going to suction that patient. And then what we're going to do is when we have our clean gloves on, we can go and remove that gauze at that particular point. Then you can also, in some cases, be able to take that inner cannula out, especially, if you're going to throw it away or something along that line. If it's one that you're probably going to reuse, you may want to wait till you put your sterile gloves on. If you have to put a temporary inner cannula in, say you have a patient on a ventilator and they need to go back on the ventilator, then what we'll do is we'll just go ahead and take, with our gloves, we'll take the inner cannula out, and then we'll insert a new sterile inner cannula into the outer cannula at that point. You do not touch the body of the inner cannula. You only touch the upper portion of it, okay? So where the 15mm adapter is, that's what you're holding on to when you're taking it out and when you're putting it back in. So we're going to take the inner cannula out. If it's a non-disposable one, we're going to place it in one of the mixtures. We're going to insert the disposable one for patients, and we're going to use our sterile gloves to go ahead and take out and insert the new one. And then we'll reapply the oxygen equipment as necessary. We can use the brush that you saw to clean the inner cannula out. Do not use the brush on a patient's skin, though. If you have a lot of secretions on the flange, you can take that brush and actually, holding that flange, go ahead and brush around that flange, especially on the top, and remove or loosen up the secretions. And then we can take either a gauze pad or we can take the sterile Q-tips and we can go ahead and rinse around it. Once you've used the gauze, once you've used the sterile Q-tips, those get tossed into the trash can. We do not reuse those. Then we're going to clean the stoma site, dispose of the old gauze. You can use your clean gloves, as I said, to do this. Use the cotton tip applicators, either with the 50-50 mixture or the sterile water. When we're cleaning, you can either clean the top and then work on the bottom, or you can start underneath it and then work up. Regardless of what you do, hold on to that flange. And then what you want to make sure that you're doing is you're cleaning away from the stoma. And so you get used to going ahead and put that Q-tip underneath the flange and roll that out. And if there's secretions under there, you can roll those secretions out. If the secretions are somewhat dry, sometimes what you can do is get one of the gauzes, soak it in the 50-50 water, and then lay it on the skin, and that should help loosen up some of those really dried secretions. Again, change your applicators when soiled. Do not put them back in the sterile water, even the dirty sterile water. You have to rinse anything you touched with clean sterile water, okay? Replace the gauze, but do not cut the gauze. You can either use a cloth tie or the Velcro to do it. And you want to make sure that once you have this tie on, that you can go ahead and put 2 fingers between the tie and the skin. This is enough room to be able to do that. Now, before you put To tie on, this is where you want to look for skin breakdown, and this is also where you want to look for an infection. So take one of your gauzes if you have them and put some sterile water and use it to wash behind the back of their neck. Sometimes when you do that, there may be some blood back there and that will come out. That's an indication that that needs to be cleaned. Otherwise, it's going to stay there and it may end up infecting the patient. Make sure that you also tell the nurse if that's a problem. If you do see some skin breakdown, there are wound care teams in the hospital, and they'll report that to them, and they'll come in and they'll take care of the breakdown. They'll take care of the infection at that particular point. So we need to make sure that we do all of that, okay? So now you've finished with the procedure, you got everything working for you, it's time to document. You're going to document both your pre and post procedure vital signs. You're going to make sure your vital signs are still within the steam range or better when you're finished. If you suctioned, you're going to do all your documentation for your suctioning at this particular point. The pressures, what happened to them, how did you take care of it, did you pre-oxygenate, did the sats stay good, all of that we talked about with suctioning. We're going to talk about the fact that we had a sterile procedure and went to clean. And then we're going to look to see, was there a patient response to it at that point. Now, what I'm going to tell you is, this is the way we teach you to do trach care. When we talked about suctioning, that was the way we teach you to do suctioning. However, hospitals will sometimes have different procedures. When you go to a hospital and you're going to work there, you need to understand what is their procedure for doing suctioning, what is their procedure for doing trach care. When you are a student at a hospital and going through clinicals, you need to follow what the hospital procedure is. You can stand there, don't get into an argument with a therapist. This is what I was told. I can't believe you guys are doing it. That is not your place. You are a guest at that hospital and you need to follow what the hospital is telling you, okay? We're telling you how this needs to really be done. It is now something that either you will be able to do, in some cases with the hospitals and finances and things like that, you may not be able to.